Hey everyone, and welcome back. Today, we're diving into a topic that is just so important for every single one of us in the clinic: how to spot the non-familial, or sporadic, risk factors for pancreatic cancer. For a disease that's so often caught way too late, knowing these clues is really our best shot at having that high index of suspicion early on.
Okay, so let's jump right in by really painting a picture of the clinical challenge we're up against. And make no mistake, pancreatic cancer is an incredibly tough opponent. In the United States alone, that's roughly how many new cases are diagnosed every single year. And here's the tough part. Pancreatic cancer is one of the top causes of cancer-related death. The sad truth is, most patients won't survive the disease. And this right here, this chart really gets to the heart of why the prognosis is so poor. You can see that a huge chunk, we're talking 82% of patients, show up with advanced disease that's already spread. It's incurable when they're diagnosed. Only a tiny slice of those patients are actually eligible for surgery that could potentially cure them. So this leads to the big question, right? Since we don't have a good screening test for the general population, what's our most powerful tool? Well, it's knowledge. It's about understanding these identifiable risk factors so we can sharpen our clinical instincts for the right patients long before they start having symptoms.
All right, let's break this down. First up, we're going to look at our first major category, the modifiable risk factors. These are the things connected to a patient's lifestyle and environment, things you can actually talk to them about changing.
Okay, if you remember one thing from this section, make it this one. The single most significant, most established, and most modifiable risk factor for pancreatic cancer is, without a doubt, cigarette smoking. I mean, the link is just crystal clear.
And check this out. It really shows you the difference it makes. Study after study shows that current smokers have up to 2.5 times the risk compared to people who've never smoked. In fact, smoking is blamed for maybe up to a third of all pancreatic cancer deaths. But here's the good news, and this is huge for your patients. That risk starts dropping significantly just a few years after they quit.
All right, next on the list is something we're all seeing more and more in our clinics: obesity. And with it, a lack of physical activity. There's a really strong metabolic link here that we can't ignore. So what's this number mean? Well, that's the relative risk for someone with a BMI of 30 or higher, which is in the obesity range, compared to someone with a healthy BMI. It's a pretty big jump. But on the flip side, we know that moderate physical activity is protective. It can even cut the risk almost in half, especially for folks who are overweight. Now, it's just as important to know what isn't a clear-cut risk factor, right? Or the data gets a little fuzzy. Things like a Western diet or heavy drinking have popped up in some studies, but honestly, the data is conflicting and we just can't draw a firm line. Same thing for aspirin and NSAIDs. So for now, we don't consider these established risks like we do for smoking or obesity. Okay, let's switch gears a bit. Now we're going to talk about other medical conditions a patient might already have. Think of these as clinical red flags in their chart that should make you think just a little bit harder about pancreatic cancer.
So you see a few big ones on this list. Let's start with a major one: non-hereditary chronic pancreatitis. That constant inflammation just creates a really bad environment. After 20 years with the condition, their cumulative risk of getting cancer jumps to about 4%. That's a big deal. Now here's one that might surprise you. It's not something we usually think about in this context, but it's a validated and kind of fascinating piece of this puzzle: a patient's blood type. And this is pretty wild when you look at the numbers. It turns out people with blood types A, AB, or B have a significantly higher risk than people with type O blood. I mean, a couple of massive studies found that about 17% of all pancreatic cancers could be linked back to just inheriting a non-O blood type. We don't know the exact reason why, but it might have something to do with inflammation or how the immune system spots trouble. All right, let's talk about a really tricky one: diabetes. For years, the big question has been, is diabetes a cause of pancreatic cancer, or is it an early consequence of it? It's a real chicken or the egg situation for clinicians. And it turns out the answer is probably a bit of both. On one side, diabetes can be an early sign of the tumor itself, what we call a paraneoplastic syndrome. This makes sense because it often shows up less than 2 years before the cancer diagnosis, and sometimes it even goes away after surgery. But there's also great evidence that having long-term insulin resistance is a genuine risk factor for developing the cancer in the first place. So this leads us to probably the most important clinical pearl in this whole discussion,
And it's summed up perfectly right here. When an older adult suddenly develops diabetes, especially if they're thin and don't fit that classic type 2 diabetes picture, that right there, that has to be a huge red flag for you. It should absolutely make you consider an underlying pancreatic cancer.
Okay, so what do you do with all this information? When you're in a busy clinic or running around on the wards, how do we actually use this to help our patients? It really comes down to three things. First, you got to be on the lookout for these risk factors in your patients' histories. Second, use that as an opportunity to counsel them on what they can change, especially quitting smoking and managing their weight. And third, for patients who have a mix of these risks, you just have to keep that index of suspicion high and have a lower threshold to investigate if they come in with vague symptoms.
So, if you're going to walk away with just a few key points, let's lock in the big four non-familial risk factors. Number 1, cigarette smoking. Number 2, obesity. Number 3, a history of chronic pancreatitis. And number 4, that new diagnosis of diabetes in an older, non-obese adult. These are the signals in the noise that you need to hear.
And that really leaves us with the big question, right? Where do we go from here? We're definitely getting better at figuring out who is at higher risk based on these factors. The next great challenge is how do we turn that knowledge into real targeted screening strategies that can actually find this awful disease when it's still curable? That's the next big challenge, and that's where the future of this field is heading.